Good evening, everyone, and welcome to the January 2021 NATS Chat. Thank you for joining us. I'm Kari Ragan, the moderator. NATS Chats are sponsored by Inside View, and tonight we are also sponsored by the Voice Foundation. And so I'm so happy to welcome my co-moderator, Peggy Baroody, joining us tonight.
Thank you so much, Kari, for having me. Hello, welcome to everyone. Hope you're all staying safe and healthy during this tumultuous time. On behalf of the Voice Foundation, I encourage you all to answer our survey if you've received it about whether you would or wouldn't come to a live meeting of the Voice Foundation. We're in the process of making that decision now, but we hope to see you there in one form or another.
Thanks, Peggy. I was really happy to see that, actually, that question. Yeah, I'll be curious to see what the results are.
Yeah. So will we.
So Peggy and I are joined tonight by the fabulous Dr. Nicholas Perna, who is Associate Professor at Voice Pedagogy, or Associate Professor of Voice Pedagogy at Mississippi College, and also the host of the Vocal Fry podcast, which I highly recommend if you've not listened to any of the Vocal Fry podcasts. They're wonderful. It's worth it just for, there we go, for the pop culture questions at the end. And also the fabulous Marci Rosenberg, speech language pathologist extraordinaire, works at the Vocal Health Center at the University of Michigan in Ann Arbor, and of course is also co-author of The Vocal Athlete, as everyone knows. So welcome, Nick and Marci. Thank you for joining us for what can be a little bit of a contentious topic, right? Singers, self-laryngeal manipulation, what singing teachers need to know. So right off the bat, let's just chat for a moment about what we think about that, and in broad terms, what we think about singers doing massage on the larynx or other structures nearby. What are the pros? What are the cons? What are the risks? What are the benefits? So whoever wants to start.
Well, as we were chatting before we went live, we were talking about the fact that laryngeal massage is really a very broad topic, and I think that singers and speech pathologists, by the way, have various different levels of comfort in what they are willing to do in a clinical setting. I know several speech pathologists who actually don't do any laryngeal massage, and I think as there are no guidelines really saying, you know, it's sort of the standard kind of situation that we have. There are no firm guidelines about it. So you're going to see a lot of variation with the people's various levels of comfort.
Marci, even as an SLP, what are the guidelines around from ASHA? I don't know that I know that.
So my understanding is that for ASHA, with our guidelines state that we determine our scope of competence, right? We know there's a difference between scope of practice and scope of competence. So I would not be ever treating a patient who'd had a stroke, because it's not within my scope of competence, even though it's within my scope of practice. And so it is to me as an autonomous professional to determine my scope of competence with various different modalities. So I would put the manual intervention into that group. And so based on that, as a speech pathologist, I don't believe that ASHA has firm statements regarding a license to touch, which is the other issue that a singing teacher does not have, whereas a massage therapist, a physical therapist, an occupational therapist, they sort of fall into that category. So there's a little bit of that gray. There's sort of a little bit of a gray, and that speech pathologists don't have. It's not listed under ASHA guidelines that it's a license to touch, but we are autonomous professionals that determine our scope of competence.
And within the license to touch that SLPs have that voice teachers do not have, what kind of special training do you think one would undergo in order to do some of the manipulation on their patient? I'm not talking about the self-manipulation, which is what we're really going to talk about, but I'm just curious for you to expand on that a little.
Yeah, I mean, so I can tell you, and then again, it's not that we have a license to touch. It's not sort of written that way, but we determine our scope of competence, is my understanding. But so for me, I started right out of the gate going to Nelson Roy's workshop in Albany, New York at the time. I was incredibly pregnant with my now 19-year-old daughter, and I did his laryngeal massage seminar. And then I've just done a series of manual intervention, myofascial sort of things along the way. And I've done, you know, obviously having been in practice for almost 20 years, I sort of feel very comfortable and facile with it now, but it's because I've been doing it so long. But I think there is a certain extent of like you're learning while you're doing, which is, you know, I mean, there are cons to that. And so I think that's where it becomes the responsibility of the clinician to be appropriate with what they are doing and how aggressive they're being and what patients it's appropriate for and what patients it's not appropriate for.
Okay.
Can I ask a quick question for Marci? And do you think that your understanding of anatomy and physiology, which is part of your training, informed or made the process of learning these techniques easier and perhaps safer?
I would say that I think that my level of understanding of nerves, of coexisting conditions to be mindful of, I think those kinds of things are certainly very much on the radar of a speech pathologist, or at least I would hope they would be. I mean, there are definitely contraindications, and we were talking about this a little bit. So, I mean, to me, anybody who has a significant carotid history, whatever that is, I'm not going to get in and be aggressive. Hypermobility issues are another thing that somebody may not think about. And Kari, you were just stating you have a client that you're working with who sort of falls into that category. And that might not be something, by the way, that they're going to volunteer as relevant information when you're getting a history from them. And so even a singing teacher who's getting a history, I mean, you know, the patient might not even occur to them, or the student that having Ehlers-Danlos syndrome is maybe something that somebody doing manual intervention might want to be aware of. So I do think as a clinical provider, having that background is helpful. But then I, you know, really made sure that I was really understanding and augmenting that knowledge that's fairly basic to make sure that I really have a keen understanding of the anatomy and the nerves that are involved.
Great points. Thank you, both Peggy and Marci. That is so important. Well, Nick, so let's bring it back into the realm of the voice teacher with, you know, tonight talking about self-manipulation or self-massage and how we as voice teachers might guide that. And I know you're going to take us through your presentation since you actually did some research, but would you like to share up front just some thoughts about this topic?
Yeah, I have two thoughts actually based on the conversation we just had. One, every time our team presents, our perspective is that and this is just my own philosophy as a voice teacher, is that voice teachers should not be physically touching their students. Beyond even any legality issues, I just philosophically don't think it's necessary. Now, full confession, 10 years ago, me did not agree with that. So just not to, you know, make anybody feel bad because it's part of their practice. I've just changed because there are plenty of issues that we could talk about there on a different NATS chat. But our perspective is voice teachers are not licensed to do this. The second thing I was going to say is I asked, so one of the centers around the United States that definitely does this is Vanderbilt. And when we were getting ready to do this, at Dr. Tom Cleveland's invitation, I visited Vanderbilt for a day and got to observe their physical therapists do this for a day. But what made me think of this in this context is one of the questions I asked him is, what would it actually take for a voice teacher to be licensed to do this? And he said 4 years of school to go to school for physical therapy and becoming a physical therapist. That was his response, because I believe, as I understand it, at Vanderbilt, they actually don't even have their SLPs do this. It all goes to their PT department.
Wow, that's
which is who I observed. I observed 2 physical therapists for a day through all their clients, except for one who was apparently too famous for me to observe. but I got to observe, that's the truth. They were escorted in through a back entrance and I wasn't able to view their session. But I will say that day was very inspiring to me, just since we're talking about it, because we had already sort of been planning on going down this road, and I had mentioned it to Dr. Cleveland. That's why I ended up there. But it was interesting because watching these two women work on patients, we'd have sometimes patients would come in, either basically hoarse, or I remember we had one come in who sounded very close to laryngitic. It had a gig the night before, was a contemporary singer, had been out in Nashville, doing the thing, whatever. It was actually the first patient, I think, of the day, like 8 a.m. or 9 a.m. or something. And very not great shape vocally, and an hour-long intervention. And I swear she sat up and went, "Oh yeah, I feel a lot better." And I was like, so I mean, the thing is, there's enough anecdotal evidence pointing to some efficacy of this that even if the research hasn't told us whether it is or it isn't, which is something I'll talk about in the presentation, but we can't ignore that there's good anecdotal evidence from therapists that have, good bedside experience saying that there is benefit to it. So, I mean, that's just one of the first things that I would say. But yeah, voice teachers, I don't think we should touch our students.
And I just want to interject very quickly. Good, wonderful things, Nicholas. First of all, voice teachers aren't licensed to do anything, much less do massage. So that's a dilemma that we work with all the time. So what
Absolutely.
that means is that if a voice teacher wants to do some type of massage or wants to understand the safe way to go about any type of massage, they should get some training in it. And secondly, I would say I certainly understand people who don't want to touch their singers at all, but I would say that that is not a necessity, especially with asking permission. But I think one other thing that we didn't mention, and I'll just mention very briefly, is that not only are with laryngeal and massage of this area, not only are there physiologic issues and anatomical issues we have to be mindful of, there are also psychological, emotional issues that can suddenly arise with touching somebody in this part of their body if you don't know their history. So it's a minefield, but not necessarily one, in my opinion, that teachers need to avoid. But that's all I want to say about it. Sorry.
Okay, that takes us back into, somebody, us touching them, which we're not talking about, but even with a physical therapist doing that, that would be the case. Have you guys ever had somebody who's had some trauma where you're guiding them to self-laryngeal massage have a reaction? Because Peggy, you were talking about somebody else. Have you? I never have. I've had only positive. When I guide them through different stretches and massage, it's always an extremely positive response. But have you had the opposite?
In my time in the medical practice, I would say I had at least 3 people who could not touch their own throats because of previous trauma. Okay. So it does exist, but sorry.
No, that's perfect. That's exactly what I wanted to know. And I just wanted to just tag on. I shared it privately and I won't belabor it, but Nick, I love that those physical therapists work on the team. Like we have a local physical therapist who really knows singers, and that's who we're all working in collaboration with because there's a particular understanding. So obviously their physical therapists work with the voice team. So there is conversation and collaboration that's specific there. But I recently, had a singer contact me because they had a physical therapist do some manipulation that 10 months, they somehow traumatized a nerve is what they're thinking. And 10 months later, this person is still hoarse, having swallowing issues. That's the scary part as well. And it's going to take a whole team to kind of unpack that. So again, we want to encourage people to find the right people to work with because of the complexities of this area.
Can I say one thing about that in response?
Please.
This will transition us to talking about us touching ourselves rather than a therapist intervention. I think nicely. One of the things that a therapist might, is doing is they may, depending on, what again, style of this we're talking about, exactly, you know, the individual practitioner, whatever. There could be, in some cases, perhaps more aggressive techniques in some schools of thought than others. But I don't know that, I mean, again, they could get toward a nerve or something, or get toward the carotid. We're always kind of, you know, trying to get people toward the midline if they are going at the larynx. But the idea of, I don't know that someone touching themselves would do something so rigorously, but at the same time, inevitably, some of us can get eccentric, and we think a good thing, and it will take a good thing so far. So it does, all of this is, it's a complex, you know, set of issues. But one of the things we usually say that my SLP sort of said to me on our team when we were looking at this was, you know, you would never have a ballerina who's afraid to massage their feet. You'd never have a sprinter who's afraid to massage their calves. And so the idea of, because we do have a lot of muscles, a lot of the tissue is muscular. Yes, we have cartilage and there are nerves and that we need to be aware of, and this kind of thing. But the idea of just not touching it at all is perhaps misguided. I mean, I don't think we should have fear, I guess is my point. Yeah. Guidance, yes, but maybe not fear, because being in touch with your own instrument, just I'll say from my own experience, can actually be an emotional thing, but it can be a really, even from a technique standpoint, you know, give you a different body awareness that can give your brain a whole new, you know, understanding of what's really going on. Anyway, that was what I wanted to say.
I'll add to that, Nick, that we were kind of touching on this before we went on, but when I teach, I do teach most of my patients to complete some variation of the maneuvers that I'm doing on them. But I do have to do my own sort of calculation of, are they a bull in the china shop? And are they gonna, like, is this an engineer who, if I say do it for 2 minutes, is gonna say, well, 20 minutes has gotta be better than 2, so for sure I'm gonna do that, and super aggressive, you know, or is it somebody who's barely afraid, you know, to touch and everything in between? And as I was mentioning, I don't give handouts out when I teach them how to do the maneuvers, because I don't want it, to use Peggy's words, it's not a one size fits all. And the maneuvers have to be tailored. It's got to be very patient specific. And while we all have kind of a general thing that we tend to do, there's got to be room for a lot of nuance and variation, you know, across patient. The last thing you want to do is hand out a handout or something like that, and then have that person take that and think that, okay, great, and then show that to their friend who's also a singer or a teacher. And then the next thing you know, you've got people who don't really know what the nuance was behind it. Trying to do something.
Before we go to Nick's presentation, somebody has written in a question. Stick with me, it's a little long. This person says they're a voice teacher who lost their voice due to tremor and vocal dystonia. Recently, they've started taking dopamine and the voice is responding miraculously. The voice therapist, somebody at the Cleveland Clinic, speech language pathologist, started me on a program of self-laryngeal manipulation. This person also has fibromyalgia. And after she massaged me to show this person how to do it on herself, she felt bruised, almost bruised. And this, the therapist said that sometimes that happens with people with fibro patients. And this person is, this voice teacher attendee is afraid to do it again. Do you have people that feel pain sometimes?
Yeah, and that's where you have to really be sort of thoughtful about how you're approaching it. And so fibromyalgia falls under so there's a whole category of sort of conditions or situations that I refer to as wild cards. And they're often like rheumatologic, systemic, sort of the, you know, chronic learned pain syndrome, you know, there are all sorts of things that fall under that. And what that means as a wild card to me is that it's almost 100% playing a role in whatever it is their symptom is that they are describing, or the pain or the atypical finding, but we don't know quite why. So, you know, that would be an example. I mean, there would be a lot more probing I would have to do with a patient like that to figure out what does work for that patient. Maybe they need more myofascial gentle myofascial work. I refer to an occupational therapist all the time who does that. There's not a general answer that's going to be earth shattering without having her in front, to look at. But
Nick, did you have something to say?
Well, I was just, even in a muscle tension dysphonia patient, you could end having a singing student who ended up developing MTD. They can have pretty severe pain on one side of the neck or the other. And if anyone, whether therapist or themselves, might go to do anything to it, they could experience some serious discomfort. Mm-hmm. So, I mean, again, it's like we've been saying, it's not a one size all fits thing. It's in the end with something like that when you're actually, but I think there's a difference between that and what we were doing that I want to point out, which is there's a difference when you're dealing with someone who has known medical issues, and those should always be dealt with by a medical practitioner, whatever that discipline needs to be. We've been dealing with a healthy population who were screened and who did not have anatomical, any kind of disorders, dysfunctions, whatever. And so we've been looking at habilitation rather than using this in any kind of therapeutic manner.
And the point tenderness, yeah, sorry, go ahead.
No, you go.
I was just going to say the point tenderness, we see that all the time. That's expected with laryngeal massage. And you can get significant point tenderness in someone who doesn't even think they have any tension or doesn't even have a voice problem. But if you've got a patient with other factors like a myofascial issue or fibromyalgia or something like that, and they're describing like a bruising and it's lasting, so it sort of depends on the context within that's occurring.
And I think with all of our discussion of singers as vocal athletes, I always try to remind people that unlike sports athletics, we do not believe no pain, no gain. So whenever I do any form, or even in singing lessons, but any form of massage, I talk about the fact that I don't want them to experience pain of any type. I'm not comfortable with that. When you hit those points, Marci, do you proceed with it? If you find a tender attachment point, do you work into it a little bit?
Right. So it depends on other diagnoses that patient may or may not have. And then I have that I always have that closed loop conversation with the patient where the patient is driving the bus. They are in complete control of my pressure level. And Walt Fritz actually talks about this a lot in his, where we establish a scale of pain on 1 to 10, 10 being completely intolerable. And I am always saying, where does that feel? You feel tenderness? Oh, it's about a 4. Great. What number would you let me get to before you said stop? Oh, I'd let you get to about a 7. So that tells me my margin right there for like how much I can play around. And it's that constant dialogue so that they know they're in total control. And they know that they trust that when they tell me that is too tender, I'm not going to say, no, I know better, actually, you need to go. And that they know that I will let off. Because the last thing you want to do is trigger more tension. And you don't want to trigger a response of a protective response.
Right, the bracing.
So I think that dialogue is very important when you're doing laryngeal massage. So yes, I'm comfortable moving forward with points of tenderness. I tell them that I'll probably stumble upon them, that I'm actually looking for them. But we kind of establish that rule ahead of time where I tell them to give me a thumbs up, a thumbs down, show me the number, that kind of thing while I'm doing it.
Nick, let's jump into your presentation and share with everybody that may not know about the research that you and your team did.
Yeah, so can I minimize this? Well, okay. All right, so here we go. We already know our topic. What we've really been looking at has been, what is the efficacy of a healthy singer doing this on themselves? And forgive me, every time I have LM, I mean, you can use whatever, laryngeal manipulation, laryngeal massage, whichever term you like. There have been, again, some studies that have shown from a therapist, perspective that the therapy provides benefits in disordered voices. There was also, I want to really point out this particular lit review, because if you want to actually research this topic, this lit review is a very, very thorough, systematic analysis of the research on this topic. and I love their quote. This is actually from their abstract. Various types of laryngeal manual therapies are available with similar objectives and effects, but the effectiveness is equivalent to that of the other interventions involving direct voice therapy and the rehabilitation of adults with behavioral dysphonia. One of the things that they did in that lit review was they honestly I think they looked at 270 some studies, and they really only found 3 to be reliable. But when we think of reliable, when we're thinking of research, we need to have controls in place and clear protocols. Most of the literature that's examined this has been on a therapist intervention. And as Marci so beautifully pointed out, the therapist intervention, they're going for what the patient needs, not always trying to do the exact same thing. And so one of the things about looking at this is it's a very complex thing to try to research. Let me get control of my screen again. I want to just give credit to our team at the medical center. We have this joint partnership between the University of Mississippi Medical Center, where I'm a research affiliate, and Mississippi College, where is actually my professorship. My colleagues, Dr. John Schweinfurth, who's a professor of otolaryngology, he's our PI at the Med Center. I'm our PI at the college. And then my dear colleague, Josie Alston, who's our chief of speech language pathology. And I'll give Josie a lot of props because she was very much responsible for making this whole relationship happen in the first place, and was just very grateful for her contributions. But we were curious that she at the time we had a bunch of actually MTD patients, and she was kind of curious that singers did not touch their own necks, because that was what all the singers were reporting that. And she was kind of like, really? And so, so what we desired to do was we said, okay, if we're going to actually look at this, the first question really is, is there empirical evidence that we have any efficacy with this happening? And so our big research question was, does self-laryngeal manipulation aid in preparing a singer for optimal performance? And so what we did was we basically compared treatments. We obviously know that most singers vocalize, so we used a pretty, what I consider to be a pretty standard vocalization with respiration exercises like hissing or panting, and SOVTs, scales, arpeggios, a basic 10-minute vocalization. We compared that to a day of silence, and all these happened on different days. So we would have someone come in and we'd do some pre-measures to get a baseline of where they were. We'd have them do the intervention, and then we would take their measurements afterwards. So we did a vocalization day. We did a day of silence in the first test. We did a day of just laryngeal manipulation. We did one then where we combined. They did the laryngeal manipulation video, then the vocalization video. For the retest, we actually did that, and we flipped it and had them do vocalization first and then laryngeal manipulation, which I wish we would have done for both. This is my lovely protection of subject anonymity, my lovely squiggles on the right. But here's how we're controlling our instruction for this. What we're doing is, whether it's the vocalization or whether it's the laryngeal manipulation, we have instructional videos that the idea was to have a 10-minute activity. It actually takes a little bit longer than that, but it's 10, actually we timed them out per area. Like when they do the masseter, they spend a minute at the masseter. And we basically did 10 exercises of laryngeal manipulation. It was something like that for vocalizing too. I mean, and you might imagine, obviously, that, I'm obviously the singing teacher giving the prompts, but at least this way, with the video, we knew that both a visual and the oral prompt for the subject, the instruction was the same each and every time. It was the best way we could think of to control what was happening. So what did we measure? If you're into this kind of thing, this is a little bit of the science. We used the K-Pentax PAS. You have, if you're not familiar with that, you have a little pressure tube in your mouth. I actually have it sitting over here. I should have had it with me, but you just do a syllable train on pa. We actually had them sing because I wanted it to be a little bit closer to a singing task at a sustained loudness. We did it, you know, pre and post. We averaged the pre and the post together. We had measurements of airflow, measurements of subglottal pressure, and measurements then of pressure divided by flow. There had been a study on disordered patients that came out of the team at the University of Pittsburgh, where they found that laryngeal airway resistance, which is this R-law measurement, laryngeal airway resistance had reduced when they did a therapeutic intervention of manipulation on patients. And so we thought, all right, well, let's just use that as a first measurement that we're looking at. And then we also looked at your basics of sound pressure level pre and post. Our subjects were all, you know, college-age voice students because we had easy access to them. I would have had 11 subjects for both tests, but COVID. And I actually had 2 of the 3 data collection days done with my last 2 subjects. I was going to have 11 and 11, and then spring break happened, and I think we all know what happened after spring break last year. And I want to just say a quick moment about this. I realize that our N numbers in voice research are so abysmally low. I know, but it is, and that's not defensible in one perspective, but at the same time, any of my colleagues who are watching who do voice research know how difficult subject recruitment can be. And we're also just trying to produce data, so we're doing our best. They all were, at least, I didn't want any newbies, so they all had a year of voice study prior to being a subject. They were aged 18 to 30, so you know, we have graduate students, so anywhere from basically your freshmen to graduate students. Had one lovely freshman who had to wait to turn 18 to participate after they had had a year of voice lessons, and they had turned, because I guess they didn't turn 18 till their sophomore year. It was really remarkable. Anyway, homeschooling, what are you gonna do? And we had, for test 1 at least, everybody was screened for anatomy and dysfunction, which was a horrible sticking point with our IRB colleagues, because we found out that at our hospital, a rigid scope is considered non-invasive, but a flexible scope is considered invasive, and that was a huge sticking point in getting our IRB approved. It took us 11 months.
Been there.
I've never seen IRB take 11 months to get approved. Anyway, so on the first, one of the most interesting results actually came from our sound pressure level readings. On our first test, the day they vocalized, we had a mean increase of a little over a decibel, which did not quite fit the statistical level of significance. If you're not familiar with P numbers, P values, we would look for something under 0.05. We were borderline though. But when they did their laryngeal manipulation and then vocalized, we did have a statistically significant increase of, you know, with a p-value of less than 0.0001. I want to say 2 things about that. One, we did not have any significant findings on our aerodynamic measures for this first test at all. And so it wasn't like we had significant increases in subglottal pressure, significant increases in airflow, or anything else. It was just this one measurement that gave us a significant finding. The second thing I want to say about this is, before I go even further into the numbers, I want to give a huge shout out to my dear friend and colleague, Dr. Joshua Glasner, assistant professor at Clark University, who ran our statistics. Josh is an SPSS wizard, and I want to just give him a huge amount of thanks. And I would also say this decibel level increase is for the group and would fit the just noticeable difference of a decibel level increase at the pitches that we had people do the pause syllable train at. Unfortunately, as these things go, when we retested, we did not necessarily have the same results, which is one of the reasons that we should all be retesting our protocols, right? Everybody who does research, yay, except unfortunately, it's not quite as, you know, wonderful looking. But there's really good usefulness to taking a protocol and repeating it, because I was kind of suspicious of this finding, I'll be honest. I like to be suspicious and think I'm wrong. And the second time, we didn't have the same result. The vocalization, we had an increase of dB level this time that was statistically significant, but not with our laryngeal manipulation vocalized day. It didn't quite fit the numbers. So I'll come to my conclusions in a minute. Let me go to aerodynamics. Again, on our first test, we had absolutely nothing to report. None of our findings. It was so random. It was random.
That was the findings.
That was the finding was there was no finding. On our second one, and I got to move this Go webinar. Here we go. On the second one, we had on the day for airflow, only on one day did we have a statistical significance, which is the day that they vocalized and then did the laryngeal manipulation. And unfortunately, what I would have hoped would have happened that day was that we would have had an increase in airflow and we had a decrease in airflow. That was not at all what I was hoping, but it was what happened. And so we're reporting it. Also, it was the day that they did laryngeal manipulation and then vocalized in the second test, we actually saw an increase of laryngeal airway resistance, which again is a measure of subglottic pressure or intraoral pressure divided by airflow. And that was, 0.021 was our p-value on that. It was within the realm of statistical significance, but again, it was not what I would want to see. I wouldn't want to have more airway resistance, and I wouldn't want to have less airflow on any of these days. And yet, that's what we saw. I'll say one last thing about this slide, which is that we had quite a large standard deviation on that last one, and I'll be completely honest with you, NATS family. I got these numbers right in the middle of May, or maybe early May, right when COVID hit. And so I have not had the brain space to actually spend the time I need to with these numbers to actually write them up, which is why I haven't written the article yet, because I've been dealing with making music online in real time. If you know me, that's where my time has been going the last 9 months.
Nick,
yes,
oh, sorry. Just a quick question, because when you mentioned that there was a decrease in airflow, or the decrease in airflow, right?
Yes.
Could that ever indicate more efficiency? I mean,
of course it could. Absolutely, it could.
That's what I was thinking.
It doesn't necessarily mean it was bad.
Right. I wanted to make that point, because that was my first thought was, well, that could be good news.
Yes, absolutely.
Exactly. That's because they didn't have pathology too.
Correct. Yes, because remember, all of these were basically healthy, normal college students. So we had both tests showed increases in SPL for the days that we vocalized and that then we did laryngeal manipulation and then had them vocalized. Some of those were 3 of the 4 of those would have been significant. One would have been a little bit almost significant. That's not a thing, but almost significant. Definitely requires more investigation. Apparently, when I vocalize people, after I do a video for them and they vocalize to my vocalizing, they sing louder after that. I don't know. It might say something about my teaching. I don't know what that is. That was just a random comment. Test 2, again, we saw decreases in flow for the day that they vocalized and then did the laryngeal manipulation. We didn't see that condition in test 1. We didn't necessarily expect that. We need more investigation. Test 2, we saw increases in airway resistance for the day they did laryngeal manipulation and then vocalized. That did not occur in test 1. We had tested that, but it didn't. We had tested that treatment, but it didn't happen in test 1. And did not. One of the interesting things too there that I didn't mention with the difference in airway resistance was that we didn't have statistically significant findings for pressure and flow independently of each other. We only had it when we used them in the same measurement to come up with a different measurement for efficiency. The way you could think of airway resistance, it would be another way to consider efficiency. And again, this would require more investigation. So what have we found? We just need more stuff. we found some significant, while inconsistent, changes. And so going back to my research question, does self-laryngeal manipulation produce positive or negative changes in preparing a singer for optimal performance? Maybe.
I'm so empathetic, Nick.
Well, no, look, I think that as scientists, though, this is like where we really should all be thinking, is that rather than like having a finding and saying, aha, my p-value is low, it's really better to question everything, right? I mean, that's really where then replicable good science can come from, is if we're really even questioning our own data. So what are we going to do in the future? We want to look at different aerodynamic and acoustic measurements. I think looking at maybe, you know, either phonation threshold pressure or collision threshold pressure, whatever you call it, would be a good thing to look at with this. We could look at different acoustic measurements. Full disclosure on the acoustic measurements, I don't have a whisper room. I wish I did, but I don't. So we didn't have that kind of acoustic control to go along with this. And I'd like to repeat the protocol for cool down rather than considering it as a means of trying to prepare a singer for optimal performance. I'd love to look at it in the context of how we're recovering from a performance or a lesson or a rehearsal, because I think it might even be more beneficial potentially in that regard. And that's my little spiel. Can I just say one? Can I just say one last thing? Because I want to stop showing my screen. There we go. Yes. The last thing I wanted to say is I forgot to mention on the slide showing our team, I also want to give huge shout outs to my two former graduate assistants, Sarah Pygott, who's my Vocal Fry co-host, and Leah Oswalt, who did a whole bunch of data collection on the first project. Sarah also did data collection for me on the second test. So I just want to give them, and Sarah did the NATS national presentation with me, I want to give them huge shout outs for their help and efforts as well. So that I didn't leave them out. And I think I then remembered to mention everybody I wanted to mention.
So before I definitely want to get to, I want everybody to know we're going to be taking through some specific maneuvers with Marci. There's several questions for you, Nick, and I have one. First of all, and it's actually advice that was given to me by Johan Sundberg when I was doing my cool down and my numbers weren't, you know, I had him look at all my data, and he posed some great questions, which led me to redo the study looking for subjective measures. Because as we know with singers, and again, part of my EBVP, there's the voice research, but there's also the clinical expertise, or in our case, teacher experience, and then the student goals. So I think that this could fall into subjectively, do the singers feel that there was a difference to me? And I, as you know, I talk about it ad nauseum in my cool down study of why I felt that was important. So have you considered, and again, that advice came to me from Johan, who said, and he also asked me to add listener different, help me, expert listeners as part of it. Now, those numbers were of no benefit to me. They didn't hear consistently anything different. So, but that was information. But ultimately, the feedback from people was really significant. So that to me was significant.
Yeah. What I would say about that is on the very first study, my SLP colleague Josie did Cape V measurements on them just to see if that produced anything, and they weren't disordered voices, and so it didn't. And because it's really a tool designed to look at disordered voices.
Use ease. Look at ease, then you know about ease.
Yes. And so actually, the idea of, you know, I've done expert listener studies before, and we just hadn't gotten there with this yet. But it's absolutely easily done.
Yeah.
So
that's what was so nice about it, is that, you know, those subjective, you come up with your questions, you let them study them, and of course the ease provided some information. Peggy, you look like you were going to ask something.
I was just going to comment that we tend to put a lot of value on anything that has an objective scientific mantle to it, and to decrease subjective self-perception observations, but I would suggest that as good as our measurement systems are and are trying to develop to be, there's so much variability in the human voice. I mean, I really appreciate what you've done, Nicholas. Anybody who does a study on voice knows this. There are so many variables that you're dealing with. And our measurement system is by no means perfect. We're not even sure 100% what these numbers truly mean.
Yes,
so
forgive
I
me
think
for not saying that.
No, oh no, gosh, no.
I agree
Just
100%.
in your defense, I mean, so in terms of subjective, subjective measurement, I think that has value as well as expert.
And what surprised me is when I met for my, and I am not near as experienced with this as Nick is, but when we met with the statisticians, it was like, well, what numbers how do you want to gather the numbers? What do you want the numbers to say? I was like, well, I want them to tell the truth. Like, is that a novel idea? Any to tell me the truth of what, and it really, did I want to collect the numbers on the first of the 5 day of their protocol or on the 5th of the protocol? Right. And so it was a big learning curve for depending on when you grab the numbers, depending on what your study is set up like, you can get a different set of numbers to prove a different point. So anyway, I know you already know.
I just want to add on. So I had the exact same thought, Kari, about the patient reported experience or the subject reported experience. And I would say now, I mean, more than ever, I think in the field of pedagogy, there with what we are learning about motor learning and how we learn and acquire things, I think having agency as a singer and not being so dependent on constant external information is an important part of the teaching voice process. So to teach the singers how to evaluate, this felt effective for me, I benefited from this, I think is just as valuable as what their subglottic pressure measures are.
Agreed.
Let me just say that I completely agree. And definitely now plan to work that into the next project that we do. I would just say, not in any defense of anything, but when I got here to Mississippi 5 years ago, most of our equipment had not yet been unpacked in the lab yet. And so there was also a definite push to try to get a project done with investments that had been made. And so, so anyway, let's just roll on with that.
That was important. So, okay, Nick, let me ask you some of these questions real quick. So were there any control for one, how well the subject slept, or two, aerobic activity prior to testing?
No, there was a control to try to get them early in the day before they did any rigorous singing. But there was not a control to actually, we didn't ask them how many hours of sleep they had gotten. Although it's funny that you say that. That one had actually come into my mind at one point, and I think we had on the table for discussion if we were going to do survey questions. That was on the list. And we decided not to do it because one of the other things with this was this protocol takes like 30 minutes. When it's both activities, it's like a full 30 minutes. And again, when you're trying to get, it was a 4-day, thing for the first test. That's a lot of people's time. Again, one of the reasons for our low end numbers. And so but I had not considered the aerobic exercise. I don't remember that ever coming up in our discussions.
Well,
there's so many things you'd have to consider: male to female time of the month. I mean, you could go nuts trying to equalize that.
Acid reflux. I mean,
that actually, you did, Peggy, that is a very interesting point. We did have basically a balance of male to female subjects. Just if anyone was interested, we pretty much did. It wasn't exact, but it was very close.
And Nick, somebody wants to know if you have plans to do it in highly trained professional singers.
Sure. I mean, again, that's just adding another level of complexity to because I need them for multiple days.
That's right.
We don't do, with this protocol, you don't want them doing this, I don't think, 3 times in a day. And I don't like the idea of testing it that way. The idea was to have them fresh on a new day to see how they behaved. I mean, I could go to New York, I guess, back when New York reopens and that kind of thing. But
We have perfect guinea pigs at the colleges. That's why a lot of the
Yes.
studies are done there, let's be honest.
That's right.
Somebody wants to, perhaps the 1 decibel increase on day 1 was due to novelty. Am I reading that correctly?
Oh, I see what, yeah, just them not being used to singing in the PAS.
Got it.
Entirely possible. Again, talking about, as we mentioned, the variables. There's so many variables to control in this. It's crazy. It's totally possible. I actually had questioned that. In fact, I said this when we presented the first test at Voice Foundation in 2019, 18, whenever that was. I don't remember what year it was now. But when we did, that was actually one of my possible hypotheses that I had thought of in my mind for the last day, was that they had gotten really comfortable singing into it. And so the reason we had a statistically significant increase in dB level the day that they had done the vocalization and the LM together was always the last day. And they had gotten comfortable going pa, 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 so that's one of the reasons I thought that might have happened.
The learning effect, yeah.
And somebody wants to know if any of the changes, the mean flow and the other are due to the manipulation increasing inflammation in the tissue, causing some amount of minor plasma swelling.
I can't even guess.
Good answer. This person just said that they think it would be beneficial post-performance. I have to say, my instinct was pre-performance. Both actually was my first thought, because just like the cool down, it's the same exercises I do with the warm-ups. Essentially, you just structure them perhaps a bit differently. So I would, in some ways, if they've been talking all day, doing some of this before they start their singing, to me is smart.
I agree. One of the things people usually ask me with this is, do I do this to myself? And the answer is yes. And when I particularly do it, remember back when we used to go outside of the house and have live performances, like back before March? When I've taught all day long and then had to do an evening performance, that's when I have found, particularly just even basic palpating my larynx, really, really useful. Because as a tenor, it's easy for me to just kind of get high and then all of a sudden I can't sing low. And I know that, like, one of my big tells is if I can't sing low, it ain't gonna last very long, me singing high. And so that's one of the times that I've found it very useful. But I also find other things useful, like doing basic SOVTs.
So Marci, you're going to take it away with some.
Yeah, and let me just put up, because I just think it's prudent to just go over what I think might be contra indications.
Oh, I was thinking we didn't get that to work. Do you want me to make you?
Oh, I thought you guys told me it did work. Okay, no, I'll just read them. It's not.
Oh,
it's not the end of.
You got okay.
I still have the share. If you want to switch it to her.
I did. I've switched it.
So are we on?
Sorry, you were right. I'm sorry, Marci.
That's okay. I'm so used to Zoom that I can't. Can you guys see my slide? Okay, so just to say, hypermobility issues, so pain. So we talked about pain. In my mind, pain I'm thinking of is different than some of the point tenderness that you might experience when you're doing self-massage. Tingling, numbness, or any kind of a carotid history. As a general rule, when in doubt, leave it out. And always, I think it's just appropriate to say, if you ever have any questions about any kind of wiggling or jiggling, consult your medical care provider. Although unfortunately, most general practitioners are not going to really be able to give you a lot of real guidance. But if you have a cervical history, or if you have any atypical high school sports injuries or something like that, and you're not sure about it, leave it out. If you're in doubt, leave it out.
Marci, for people who are not versed in this, could you explain what hypermobility is? There are a lot of voice teachers out there that may not understand that term.
So joints that go beyond a normal range of motion, and there are certain conditions that would predispose somebody to that. So Kari, we were talking before, has a client she's working with that has Ehlers-Danlos syndrome, and that's one of, I think that falls into that category. And that's not something they're going to think to put on the table to tell you about, because it's not going to occur to them to be something that is related to any intervention you might be doing. And that's a lesson I learned, unfortunately, the hard way, many years ago, with a patient that had sort of one of those less typical diagnoses. So you just have to be, you just have to proceed with caution with those things. So I wanted to mention, so I'm going to go through just some of these exercises. And as Nick and I were talking about before, there's not a magical sequence per se. And people will often say to me, what is the laryngeal massage exercise, that I need to do? Or, they want sort of a very specific thing. And what I would say is, it's not a one size fits all. You have to listen to your body and what I call follow the breadcrumbs. So you have to pay attention to what your body is telling you and sort of follow that path. Often your muscles will help guide you where you should be going. And you have to learn to sort of pay attention, and you have to learn, if there's pain that's different than pain you've been noticing. Sharp, abrupt pain is not something you should ever be experiencing. Tenderness, like, wow, that's something that feels like it could use a little attention. That might be something that you can linger on and gently sort of explore. Anything that triggers something sharp, tingly, numbness, anything like that is not normal. Okay, so let me go through, and I'll pull, before I go into the larynx stuff, the point I want to make is, laryngeal massage is a very general term. Laryngeal massage, I think, is also too specific because it only says larynx. So I think when we say laryngeal manipulation, I think really we mean a whole lot of things, and we don't really actually only mean the larynx. And I think that we cannot focus on only that structure without keeping in mind all of the other structures that are around it, right? So the larynx is sitting in a sea of muscularity with all sorts of opposing agonist, antagonist, synergist, muscles that are doing all sorts of different kinds of things. And so to not address those other things, I can sort of get into my thyroid space and do some gentle depression till the cows come home, and I might even get a temporary sort of benefit or relief. But if I'm not addressing the fact that I have tech neck, because I'm on Zoom all day and I'm sitting like this, and I've had actually some structural shifts and changes that have started happening back here. And for those of you who teach young adults and teenagers, you may notice that they have that hump on many of them on the back of their neck, and it's because of this.
Marci, are you going to, that's your only slide you're going to share, right?
I have a couple of other photos that I might, because I wanted to show a couple of other general things before I get into specific.
Okay, people are asking if you can collect.
Get rid of it?
Present button.
No. Present,
stop.
Yeah. No. If you want to share, that's great, Marci. Just make it fill your screen where you hit present.
Okay, got it. Sorry, I'm so used to Zoom. I'm not familiar.
I know. No, you're doing
melody. So let me just start with, sometimes I will go right in to the larynx, especially if I'm in a clinical setting and I only have X amount of time to do the 5 million things that I need to be getting done in a voice evaluation. However, I really do think when we are using this as sort of a daily practice kind of thing, or as part of a regimen, you need to, I think, work sort of outside in as a general guideline. So when I am doing, when I'm setting up a routine for either a private student or a patient, I will typically start with suboccipital muscles. And one of the main reasons for this is because we spend all day like this. These kids who are in online school, I mean, can tell you my daughter is literally, my younger kid is in her bed upstairs like this, looking at her computer. So, and so you've got to try to neutralize that stuff and balance. So I don't have ever any fancy fingernails because of the nature of my job. So I like to take 3 fingertips, put it right underneath the base. And this one's going to be kind of like a splaying. So first you can just hang out there. The suboccipital muscles are often implicated in headaches. So you can just hang there. You can massage there. You can also do sort of like a splaying where you're going to take your 3 fingers and slowly drag forward. The other thing I will say about almost any stretch massage is that we spend way too much time doing it. I mean, we don't spend enough time doing it. So I always say really a minimum of 90 seconds for muscle fibers to really start to release. We tend to really rush through. So what I always tell patients is if you're bored, you're doing it at the right pace. If you're not bored when you're doing the stretch, you're probably doing it too quickly. So this is a great kind of a thing to do. Now you can carry this forward, right? So you can take fingers forward and then you can take them down, right? And this is where the follow the breadcrumbs comes into play. So if you notice a little area that says, hi, more attention, go there and hang out there and put a little bit of pressure on that. For those who have really tight suboccipital muscles, you can do, so there are fancy gadgets that you can buy. You can also take your husband's or your partner's trouser sock and put a ball in it. And then this one, I'm gonna put a second ball. So this one's for a different exercise. You can put the second ball in down at the bottom so that they're touching each other. And then you can lie down on this. Now these are softer balls. You don't want it to be too hard. But now you have something that can go right under the suboccipital space. You can lie down flat at the end of the day and just sort of get the pressure points there. Now I want to show my photo of some of these. So let me.
Is that like a tennis ball?
Tennis balls, you might find those are too. They might be too hard for you. And so you can put a thin pillow over them or a towel, a couple towels. You can sort of, or like your comforter, if it's like a pillow to comforter, so that it's not quite so hard. These have a little bit of give to them. I don't want to waste a whole lot of time trying to figure out how to screen share this, but what I do is I will lie on the floor with this underneath, and then I have my butt up against the couch, and then I have my calves and my feet on the couch, so that I'm like that, lying down. And that allows the thoracic lumbar spine to sort of like neutralize to a certain extent after a day of sort of sitting like this, and hopefully get some of that appropriate curvature back, while it's also helping to release some of those muscles, so as piriformis, and then also getting some pressure points here at the same time. So feeding several birds with one scone is that, as I like to say. Now the other thing that you can do, so that was suboccipital. Okay, so then what I would say is back and shoulder blades, the same sock. You can against a wall, you've got a single ball in the sock, and you can put that, if you were going to draw a line right against your shoulder blade where all the knots go, you can roll up and down against a wall when you really are sort of getting some of those out, because this is really all undoing all of this from all day. So if you're going to be singing and wanting your larynx and throat to be all free, that's not really going to happen if this is still where our body is living from just our normal day to day. So that's a nice one for the back. There are all sorts of tools that you can buy that are so effective for getting the knots out. I don't know how many of you own this.
Yeah.
Called the back.
What is that?
Oh, it's a hook.
Yeah. If you Google like Back Buddy, this is fabulous. I mean,
I want one.
They're great.
And just like dig in. You can. This is for suboccipital. If I'm sitting there watching, Schitt's Creek with my husband, I'll just sit there and That's a show, by the way. I was not using profanity. You know, I'll just sit here.
STHITT.
That's right. And I'll just put the pressure points here to get to deal with that. So I just think it's important to know that you've got to think about more than just larynx. Yeah.
Can you, somebody asked for the balls that you specifically use, they're wanting, so if you can just tell them.
The balls that were from my ball thing
Correct.
in my garage.
Right, yes, exactly. I've got one.
I'll literally just grab these out of my ball box. There's a fancy version that you can buy called a cranio cradle, which this is just the cheap version of it. This ball is like a kind of like a rubber ball. You could try tennis balls. I would go to a toy store and look for a ball that has that's not so foamy but has some give to it so that it's not quite so hard. It doesn't have to be this big. It can be smaller. If those wanting to invest $30 or $40 in something, the Cranio Cradle is a fantastic. I don't know if any of you have a Cranio Cradle? It's like a little sort of a U-shaped. It looks like a hoof almost, and you can lie down on it, and it just cradles exactly what it needs to cradle. And it's a soft kind of a foam. But this is sort of the low-tech, less expensive version of that. Okay, so I talked about some of the external things. Range of motion for the cervical spine, because we're all doing this, and so we're starting to lose that curve that we're supposed to have in the upper cervical spine. So trying to reclaim some of that range of motion, and this is not necessarily a muscle release, this is just expanding range of motion. So sort of like that tuck, it's almost like a chicken pecking, but it's backwards to help. And you can even tell when you put your hand back there gently that it's sort of gently moving those around, because listen, your body parts stay where you leave them. So you really do, you have to kind of think about sort of neutralizing and before you can work efficiently, and certainly as a singer. Okay, so that's some of the external stuff. So now what I would tend to do after I do some of this behind stuff is I would tend to do the lower stuff here first. So some of the infrahyoid kind of front area here. So a really nice gentle one. And Nick, this one might have been part of yours. More surface would be just a very gentle looking up stretch. And I'm going through these quickly, but you should not rush these. And again, if your body is telling you, wow, that feels productive, then stay there.
I like that.
Okay.
And that is also, yeah, I mean, does it feel productive? Walt Fritz says relevant. Does it feel relevant? I like, does it feel productive? Does it feel like it's something that is doing something effective in your body? And then you can always tip, right? Ear to the shoulder. You're just looking for different levels and different ranges of motion. So, and then I'll just do it on this side, but obviously you would repeat. So when I'm doing this stretch, I feel that all the way on the inside of my ear. And then I might do some gentle nodding like this.
The pin and stretch can be so effective.
Yes.
Where you get massaged through that movement.
Yes, for sure.
Opinion about which to choose when.
Say that again.
Do you have any thoughts about when to choose which, the massaging through movement or more of the point?
I think that's patient specific. I think it probably depends on if they are feeling a lot of tenderness. I might hold a trigger point until they felt that start to change a little bit. And then I might start to introduce some gentle range of motion to that. And I think that that's when you start to get to know your body. And this is going to what we were talking about with the patient reported benefit, is that, we're training singers to be smart singers. So we want to learn what we need on any given day. So I would say I vary that, Kari. I don't have an automatic that I do.
And people are asking if you're, if you're pressing
I am.
down?
Yes, I'm opposing it. I'm opposing it. Okay, so that one's more of a surface one. And so then if I want to go a little bit more into what I would say were hopefully the scalene muscles. And again, there's no way to know that am I exactly touching the muscle that I think I'm touching, with the exception of maybe the SC, maybe the sternocleidomastoid. But what I would say is your collarbone is your landmark, and you want to get your fingertips, and you want to try to cover as much real estate as you can. I would tend to go a little closer to the shoulder, and it's almost like I'm trying to pull my collarbone away. Now, for some people, this is very, very tender. So the first thing you want to do is just hang out just here for a minute and breathe and let your nervous system kind of know that you're there and you're just sort of going to be in this area. And then what you want to very slowly do is look the opposite direction. But when I say slow, I mean this. That's how slow I mean. And if you get to a point where you're feeling like, wow, that feels like it's a relevant kind of sensation, hang out there. And then if that starts to change or reduce, then let's tip the chin maybe up to the ceiling.
Oh.
Right. So that's that's a breadcrumb. That's a breadcrumb. That's your body saying this area is relevant, and now you have to determine, do you need to let up pressure just a little bit so you can be productive in that area without making those muscles more tense? Ear to the ceiling while you're up there. So there are all sorts of things you can do, and then you can move your fingers a little closer to your midline and do it again and see how that feels. One of the things that I didn't mention before we started, and I should have had us all do, is I'm a big proponent of get a sense of what your baseline is before you muck around. So get a sense of what this feels like, what that feels like, what that feels like, and then complete one side and then do it again so that you can, so that your nervous system has a little moment to sort of take some notes and sort of integrate maybe some of the differences. Slower gets you there faster 100% of the time, in my opinion, with everything having to do with voice and voice training, actually, and definitely when we're doing muscle work. So that was that side, and then we would do the other side. And so then now I'm going to start to go, and by the way, pecs are really important to stretch your pecs. The doorway stretch is a good one also because of all of this computer stuff. I won't go over that, but so this one I think is critical. I think that, we forget how interconnected all of this muscularity is and how relevant it is for voice. And Kari, your voice teacher who emailed you that went to the PT and had the work in the suprahyoid area and then has been having issues with her voice, I think is a perfect example that you have to be careful and things are very connected. So I like to find this spot right behind my earlobe. There's like a little indentation, and I use my thumb and I put it, and I almost like I'm turning a key. I just kind of, and I hang there. And when you're doing that, observe what you're noticing. Is your tongue talking to you at all when you do this? Are you noticing any referred sensations anywhere? And I'm just, at the moment, I'm just holding a trigger. I'm holding some gentle pressure here. And it's kind of, I'm sort of behind the angle of the jaw. I don't know if you can see this, like right there under the earlobe, kind of right in that area. And then you can take that and carry that down also. But I just find just hanging out up in this area, and then if you want to take it up under the jaw and the tongue is not, we talked about this is a laryngeal massage. I think the tongue is even more important and the jaw even more important than doing laryngeal massage, honestly, but that's another NATS chat. But you could get up in here under the rim of the jaw and really really dig there. So that's the behind the ear. Okay. Underneath the chin, so submandibular. This to me is a critical area. And what I say to my patients or my students is, as they're doing this, is, you know, just take notice of how taut does it feel. I mean, it should feel, if you're not talking, it should feel relatively mushy.
Mm-hmm.
And some of this will depend on your anatomy, right? And what your tissues are like and how thick your neck is and how much you're going to be able to feel. But knowing what your baseline is. Now, I will say take the thumb and the middle finger. It's just what I want to be doing, is showing my neck a full close. So I'm going like here. Can you see that?
Yep.
Can you see that? Okay, so I tend to do these two. And then what I say to my students is, or my patients is, I want you to push up towards the top of your head and angle it back, like you're angling back here, and then gently pinch in. And it should change your resonance if you were making noise while you were doing it. You are nowhere near the hyoid bone. This is all soft tissue. You should not be touching any bone. And really get in there and squeeze. You can gently move back and forth. You can do a gentle up, back, and down, a very gentle circular motion. Now, as you're moving side to side, the hyoid is going to go with it, but you're not even touching the hyoid.
Yeah.
If you're having your students do this and have them sing something before you do any of this intervention, just so they can get a sense of what it feels like, and then do whatever the intervention is that you're doing, and then have them sing it again and see what they observe. So this is a big one. This is tender for a lot of people. This is the area that that I think is the area that gets choked up, or the area where we have a knot in our throat. And those terms are exist for a reason. These muscles are exquisitely sensitive to stress and anxiety. And Peggy, we're talking, I can't remember if we were on the webinar or not, but you know, there's for a lot of people, a lot of emotional luggage that is held in this area. So always sort of proceed at the pace that's comfortable for you and all of that kind of stuff. But it's not uncommon to have a lot of tenderness up in this area. So that's up in this area. So now let's go to the actual larynx. So I tend to start, if I'm doing something on somebody, I come at them from the front like this. If I'm showing them how to do it, I like the 3 fingertips, because it allows you to kind of just feel. Now, just let it set in on the sides, and don't grope around with your fingers. Let your fingertips acclimate to where they're at, so they actually know what they're touching. When I teach laryngeal massage to patients and they're trying to find landmarks, there's a lot of groping. They've got to give the fingertips a minute to get the lay of the land. So this first one would be just the gentle side to side. And mine wiggles around a lot because I kind of do this a lot. Your student may not have a lot of range of motion. Have them observe just one side have greater range of motion compared to the other side. There may be some asymmetry in what they're experiencing. And this is just very gentle. And I'm actually going through these very quickly. I would be spending more time.
You know, and that's, as you're saying that, because I always think that too in lessons, it's like, I would love to take 15, 20, 30 minutes, but then, you know, we're singing teachers. And so it's always that balance time. But anyway.
Absolutely. I have the luxury in a speech in a clinical setting. I can spend, and sometimes I'll spend the whole session on myofascial work and massage and all that, and their voice will be significantly changed. And we have not done a single voice
Absolutely,
exercise at
of course.
all. But the you know, that's the pro of being in a clinical setting. The con is that I'm not able to do some of the lengthy singing stuff. But so then
people are asking about clicking. What if there's clicking?
That's normal. So clicking, so that's called crepitus. And that, the way I explain that to patients is that's just your structures moving on top of your other structures. And that's actually considered a normal thing. And that's considered a good thing because that means things are moving around. And you may notice that change as you start to improve that range of motion. And again, this might be a place where you're monitoring for dizziness, you know, anything woozy, you know, because we've got some important real estate here, carotid arteries, and some pretty important things running through those. So we don't want to trigger what's called a vagal response, which would be where you would start to get woozy and lightheaded. And then if you didn't stop, you know, you could potentially pass out. That's actually the Vulcan grip. That's what Spock did. He was triggering a vagal response. So if you ever did notice, this is why I say don't do this when you're driving and don't do this in the shower. Until you know for sure that you tolerate it and it never makes you dizzy. Do this when you're seated. Do this, you know, when you're in a relatively protected environment. If you notice any kind of woozy, dizzy, weird, queasy, stop and get flat. And it will resolve. It just means you've stimulated it a little bit too much. People have different levels of tolerance for stimulation in this area. In my 20 years, I've only triggered one vagal response. And I've done, you know, I've done a lot of laryngeal massage, but it's, you know, it definitely can happen. It certainly happens in otolaryngology clinics because we're poking around in areas where that's a risk. You can take the fingertips up higher now so that you're around the hyoid bone. For those who are not as familiar with the anatomy, the hyoid bone is the one bone that's hanging out in there. And if you pinch in on it, you'll feel it, it's firm. And you can gently move that. You can vocalize while you're doing this kind of stuff. Ooh, I do that kind of stuff. That's totally fine. So this would be a gentle way to approach the larynx. So this is for somebody who you think feels like very nervous about doing it, or if you think somebody's going to be a bull in a china shop and just take your instruction and really go a little overboard with it, I might just start them with something like this. If you're wanting to guide a singer to kind of explore that thyrohyoid space, that's where I would say find your Adam's apple and swallow. And that's it for those who don't. Many of us can go right to ours. And then take your thumb and your middle finger and put it right on the Adam's apple. And then slowly walk it backwards until you settle into a little indentation. And just kind of get a feel for what that little indentation feels like. And then what I would have them do, I would not guide them to do, I would not guide a singer to do that, you know, fairly aggressive, trying to increase that thyrohyoid space kind of thing that I might do in clinic, but I don't tend to have to be that aggressive. But certainly some gentle circular massaging, visualizing nice open throat, observing what the tongue and jaw are doing while you're messing around in this area. Because your tongue and your jaw and your larynx are Facebook friends. So they're always communicating. They want to know what the other person's doing. And there could be you're doing something down here, you may notice something happening in your tongue. And so then the other thing I would do is sometimes as I'm sort of gently pulling down, I might have a gentle extension out of the tongue. I have a whole tongue sequence that I do with patients, which is I think even more effective. It's a whole different probably NATS chat, but I find tongue and jaw work yields wonderful dividends.
Yeah.
When worked on appropriately. Let's see.
Let's do just one more, Marci, as we're headed to 5:30, or we're headed into 90 minutes. So let's can we do one or two more quick ones? And
yeah, well, none of them are quick, but yeah. So let's do. So I did the keyhole. I would say, so if we're doing the hyoid, you can gently kind of do a gentle kind of an upward, and then a side to side. You'll find that changes the resonance like this, because I'm now up into the underside of my tongue. But again, you shouldn't be grabbing. And it's very gentle. You're almost just sort of guiding it. And then let it return to neutral. Spend time in between these stretches, letting your nervous system integrate what you're doing. Let your brain take some notes. Close your eyes, tune in. What does my space feel like? What's my tongue feel like? Move around, make some sounds, and then maybe move on to another exercise. Slower gets you there faster, 100% of the time.
Great.
that's so great, Marci. Oh my goodness, you're so generous to give us. And I know there's, like you said, we could do a whole one on jaw and tongue. So maybe we need to talk about that for next season.
Sure.
Getting more on the even more inside. So thank you. Well, you guys, thank you so much for this. Obviously, it's a hot topic. We had great registration, and I'm sure we'll have even more people watch the archive. And Nick, thank you for your work on this. I mean, I think that research is getting a really important conversation going, and I really appreciate that.
Yeah, if I could just say one last thing really quick. Another young up-and-coming researcher, Chip Dugan, did a doctoral essay on this, did a big survey of SLPs, just finished his D.M.A. last year, and his dissertation has a really good lit review in it on this topic, and also just the survey itself is really valuable too. So I just want to point you to his dissertation. I'm sure it's on ProQuest and all that kind of stuff.
There's a new survey coming out for speech pathologists. I just reviewed an article for a journal where they've tried to protocolize a kind of assessing laryngeal muscular tension with sort of a little bit more of a systematic. So I mean, it's definitely on the radar, and I think more to come in that field for sure.
Great.
Well, thank you everyone for making such valuable points about how we can do this safely and effectively, intentionally, with care, but that maybe we need to not be so afraid. So thank you very much. And I want to remind everyone that the next NATS chat will be February 21st. And as I believe this next decade is going to be a lot more about cognition, thanks to Katie Verdolini, Lynn Helding and her fabulous new book, Lynn Maxfield, and others who have led the way. Of course, Marci and Wendy have a section in their book on this. But I'm going to have Heidi Moss on and Dr. Indra Viscontis. I hope I've said her name right. And we are going to be talking about singing in the brain. So I'm really looking forward to that on February 21st. So
excellent.
Good stuff. Yeah.
Thank you, everyone. Stay safe, wear your mask, and we'll see you all in February. Good night, everyone.
Thank you, Kari. Bye,
nice
everybody.
To see y'all.
Nice
Really
to see you too.
Wonderful.
Yeah.
Thank you as always.